Hi guys, as we completed bacterial meningitis, to comprehend the disease more thoroughly, let us discuss a case. Already you have case and you tried to solve, then also I will dictate the case. Later we will discuss it in detail. Mrs. GT, an 88-year-old woman who lives on her own, presents with a 3-day history of fever, headache, and vomiting, and a 1-day history of altered consciousness. She was taking 7 different drugs, including furosemide for heart failure. On examination, she was ill looking and had altered consciousness. Her Glasgow Coma Skill score was 9 by 12. She was febrile, her temperature was 39.2 degrees Celsius and had marked neck stiffness. The remainder of the physical examination was unremarkable. A brain CT scan demonstrated no parenchymal abnormality. For further assessment, a lumbar puncture was then performed. CSF analysis showed leukocytosis, that is 90% polymorphs, high protein concentration and low glucose level with a decreased CSF to serum glucose ratio. No organisms were seen on gram or acid fast staining. Now let us interpret this given informations. Coming to the history of present illness, that is what all signs and symptoms are presented by the patient. So this woman presents with fever, headache, vomiting, 1-day history of altered consciousness. Coming to the past medication history of the patient, here this patient is taking 7 drugs and those names of those drugs are not mentioned. They only mentioned that she is taking furosemide for heart failure. On examination, let us see what are the findings. Although the patient is ill looking, on physical examination, altered consciousness is observed. So, this opinion we can make with the help of Glasgow Coma Scale score. So, here you can see the Glasgow Coma Scale. So, it is a neurological scale which aims to give a reliable way of recording the conscious state of a person for initial as well as the subsequent assessment. We can assess the physical response such as visual, verbal and motor responses. So the total score is 15. So which indicates the patient is having best response. And when the score is 8 or less, patient is in comatose condition. And when the score is 3, it indicates the patient is totally unresponsive. As the score of this patient is 9, it indicates the patient is in a stage of altered consciousness. Since the patient is having fever, so by measuring the temperature, we got the temperature of 39.2 degrees Celsius. So what is the normal body temperature? Normally, body temperature is 37 degrees Celsius. A temperature above 38 degrees Celsius most often considered as fever. In case of this patient, she have 39.2 degrees Celsius which indicates fever, which further indicates, which in turn indicates infection or illness. Then the physician tries to examine the patient for checking the nuchal rigidity and Kernick's and Brudzinski's signs. So while examining, neck stiffness found in the patient. So the most common symptoms of this patient include the meningeal triad of fever, stiff neck and altered mental status. So this includes in altered consciousness also. When all 3 of these features are present, as is Mrs. GT's case, meningitis should be strongly suggested. Now, to confirm the disease, we have to conduct the laboratory tests, right? Here, brain CT, lumbar puncture, gram staining, as well as acid fast staining are performed. According to the most recent practice guidelines for the management of bacterial meningitis, a CT scan should be obtained before lumbar puncture in patients with specific criteria. These include immunocompromised state, history of CNS disease, new onset seizure, papilledema, abnormal level of consciousness, and focal neurological deficit. So, this patient is having altered consciousness. So, we have to conduct the brain CT. Although controversial, brain herniation can occur when lumbar puncture is performed in patients with elevated intracranial pressure because of the pressure changes induced within the cranial vault. Now, coming to the lumbar puncture, careful examination of the CSF is essential to confirm the diagnosis of meningitis. So, by performing the brain CT, our finding is no parenchymal abnormality. So, we can conduct the lumbar puncture and we can collect cerebrospinal fluid for analysis. In acute bacterial meningitis, the CSF is often purulent, containing numerous WBCs with a predominance of polymorpho-neutrophils and often is turbid. So here you can see the WBC with the leukocytosis, that is 90% polymorpho-neutrophils. Then normally in bacterial meningitis, CSF protein nearly always is elevated and the CSF glucose concentration is low. Here also you can see Mrs. GT is having higher protein and decreased glucose in the CSF. In contrast to bacterial meningitis, CSF obtained in viral and fungal cases of meningitis usually is clear and characterized by a much lower WBC count with a mononuclear or lymphocyte predominance. Although the CSF protein concentration often is elevated, it may be normal. A variable effect is observed with CSF glucose. So, we have to compare the CSF analysis to rule out whether the infection is bacterial, viral or fungal. Okay. Now, the microbiological evaluation should include examination of CSF by gram stain and culture, as well as you can do cultures from other potential sites of infection. So, the absence of organisms on gram stain by no means rules out infection but does make selection of empiric therapy more difficult. Here, Mrs. GT has a negative gram stain, which may be the result of previous antibiotic therapy or the early detection of disease. Here, acid fast staining is also performed. So, it indicates that the result was no organisms, which indicates the patient is not having any tubercular meningitis. Given the negative CSF gram stain result, this woman must receive antibacterial therapy sufficiently broad to cover all pathogens associated with meningitis in her age group until the results from CSF culture are available. So usually within 24 to 48 hours we will get the CSF culture results. The CSF culture nearly always is positive in purulent meningitis. Although CSF cultures can be negative in patient who clearly has meningitis, particularly with antecedent receipt of antibiotic therapy. Now coming to our questions. Our first question was, what are the likely causes of meningitis, meningitis. From the triad of symptoms, necrosigidity, fever, and altered consciousness only, we can suspect meningitis. The CSF findings, polymorph leukocytosis, low glucose are strongly suggestive of bacterial meningitis. Also, the age of Mrs. GT is 88 years, who is at great risk of infective agents such as Streptococcus pneumoniae, Neisseria meningitidis, gram-negative enterics, and Listeria monocytogenes. Now coming to our second question, what antimicrobial treatment would you prescribe? So, empiric treatment with ampicillin and third generation cephalosporin such as ceftriaxone or cefotaxime would be appropriate. So, usually for the elderly patients, the empiric treatment is with vancomycin, ampicillin and third generation cephalosporins. As this patient uses furosemide for her heart failure, the use of vancomycin, which is an aminoglycoside, can cause renal problems. Although some patients have developed nephrotoxicity and or ototoxicity while taking furosemide and an aminoglycoside. It has not been established that this was a result of an interaction. So, the decision to add an aminoglycoside will need to consider the risk for toxicity in an elderly patient who is receiving furosemide as well as the clinical condition of the patient. Our third question is, if after 24 hours gram-positive bacteria were isolated from the CSF, how would this change your management? So, it depends upon the organism. So, if we are isolating gram-positive bacteria, it could be gram-positive aerobic bacilli listeria, that is Listeria monocytogenes, or gram-positive aerobic cocci, streptococci, that is Streptococcus pneumoniae or pneumococcus. So, depending upon these two organisms, treatment changes. In case of gram-positive aerobic cocci, streptococci, we can use the treatment penicillin G or ampicillin, because penicillin resistance is not mentioned here. Assuming the strain is penicillin susceptible, we can treat with penicillin G or ampicillin, and the treatment should be continued for 10 to 14 days. Now, coming to the gram-positive aerobic bacilli, that is Listeria monocytogenes. So, if the patient is having this Listeria monocytogenes, it is highly risky. So, we can treat the patient with penicillin G or ampicillin, because penicillin resistance is not mentioned. We can assume that the strain of gram-positive aerobic bacilli Listeria monocytogenes is penicillin susceptible. Hence, treatment should be continued with penicillin G or ampicillin for at least 21 days or more than 21 days. Thank you.